Today, I'm honored to welcome Dr. Marlene Maheu, founder of the Telebehavioral Health Institute and the originator of the framework for telebehavioral health competencies for ethical telebehavioral health and online counseling. Dr. Maheu is a licensed psychologist and practicing clinician. She is also the author of many books, including A Practitioner's Guide to Telemental Health, How to Conduct Legal, Ethical, and Evidence-Based Telepractice. Dr. Maheu, welcome to the Therapy Show.
It's my great pleasure, Bridget. Thank you.
Can you start by telling us a little bit about your personal background and professional development that led you to your work in telebehavioral health?
Yes, I started having an interest in this area in 1994 because I wanted to start a consumer magazine online for people that just wanted to understand psychology and psychotherapy. I started a website called the Self-Help Magazine. Well, back then, we didn't have voice or audio on the internet. We just had text. People would write articles. We had some clinicians writing articles in different areas. We would have someone talking about aging issues, and alphabetically we go right down the list. We had lots of clinicians involved. We had over 300 people involved at any one point in time. It was a very big project. It was very exciting. And then I was in a car accident, and I had to decide what I wanted to do. And my options, one was to continue with some of the research I had done related to all of this online work and train professionals, because I had written some books at the time and had been thinking, I had at least two worlds, the professional training world and then the consumer world on the internet. And so I decided to let go of the consumer one and focus on professionals, thinking that I could reach more people that way. Now we have an institute, the Telebehavioral Health Institute, that we've been running for the last 10 years. This is our 10-year anniversary. We're pretty excited about it. We train professionals, and now we are in 73 countries, busily training clinicians who want to understand how to do legal and ethical practice.
How would you explain telebehavioral health to a non-professional, including what is the difference between telebehavioral health and telemental health?
There's a lot of confusion about all of this because this is sort of a moving target. The terminology has been understood differently by different people, and a lot of people want to coin a term and be infamous because they coined certain terms and things. At least that's my impression of it. But back in the early days, there was telemedicine, and it was named telemedicine because the medical community was able to get financing. They named things medical. And when that financing then started evolving out to other areas, to other healthcare practitioners, there was a big challenge at the federal level to change the terminology to move from medical to healthcare. And so telemedicine became telehealth. And telehealth, just like we don't go out and get only medical care, we get healthcare. And that includes all of the social workers and the psychologists, the counselors, the MFTs, and the nurses. So these are allied professionals that are not physicians but still offer healthcare. So then telehealth started getting more and more differentiated. And when I started writing my early books, the term was behavioral telehealth. And then somebody got the bright idea to call it telemental health, to make it one word as opposed to two. Then the federal government changed the terminology in the agency that oversees all of the behavioral world. SAMHSA, it's called the Substance Abuse and Mental Health Services Administration. They decided that they were not going to call our services mental health or substance abuse treatment because people don't like those terms, and people don't readily raise their hand when you walk in a room and say, hey, who here has a mental health problem? You don't see people running for help on that, because it's stigmatized still. So they decided they're going to call it behavioral health. Then by default, the terminology in the tele world was changed to telebehavioral. And if you go to the SAMHSA website, you'll see that. So we at the Institute used to be called Telemental Health. We started with behavioral telehealth, and then we moved it to Telemental Health to follow the community. And now we've renamed it to Telebehavioral Health to follow the federal government because they know what they're doing. At least in these decision-making worlds, a lot of people would agree that they do know what they're doing. So we're trying to be at the cutting edge of it, but still honored that we are about tele. Tele means distance, by the way. So it's Greek for distance. The other thing to keep in mind when people are looking up what's going on in their geographic area is that one of our colleagues was able to document that there literally are 25 different terms being used by different states to refer to telebehavioral health. If you go to your state and say, hey, I want to file a complaint against Dr. So-and-so because they hurt me, then you have to really ask them what the term is for practicing across distance, because they may have something like digital health or electronic health or web-enabled or all kinds of terms like that. So big confusion. Telebehavioral is the government's term, so we're going that direction.
When and how did you realize that telebehavioral health would be an important focus in delivering effective therapeutic interventions to clients?
Well, I've always been compromised by physical challenges. So I thought early on, gee, this internet, this was back in 93. I thought, this internet is going to change some things. And for people that have mobility issues, this is going to be a real game changer, because when you're really sick and it's difficult for you to walk, for example, as you get showered and dressed and in the car, drive across town or get driven across town, sit in somebody's waiting room for an hour, all of this is a huge mountain to climb. And remember, the starting point here was that you're sick. You're really sick, okay? So it's not the optimal way. And I figured if the internet can do something to bring services to people, that I want to be a part of it. And I can certainly see a big future in that. And actually, that's why I started the consumer magazine. And it was a wonderful success. We had people from around the world writing to us, asking questions about, well, what do I do if? And I remember there was one Japanese gal that wrote to us and said, gee, I was out on a date with my boyfriend and this and that happened. Do you think I'm pregnant? And I thought, oh my goodness, this poor gal, she doesn't know who to talk to, Where do you go in a little community in a very conservative country and ask these kinds of questions? But look at the door that the internet is opening for her. So I was very excited that information could get out to people who otherwise would not get it. And like I said earlier, this is back in the days when the only information we could get to people was text on a screen with pictures. But nowadays we can actually bring clinicians on board. So year after year, my suspicion, the vision I had about how healthcare could be delivered is only getting confirmed more and more and more and more over. Actually, we have a little free newsletter that we disseminate through Telebehavioral Health Institute. And I was just preparing for that this morning. And I read an article about how in China, they just did remote brain surgery over a 5G network, a 5 gig network. So this is, like I say, this is confirmation over and over again that all kinds of wonderful things can happen. And I will tell you, if we can do brain surgery over a 5 gig network, we can do psychotherapy over the internet that we have today. There's absolutely no question about it. The issue is, how do you do it legally and ethically so you're in compliance with everybody that you need to be in compliance with? And a lot of clinicians don't know that, by the way. A lot of clinicians just jump on the net and they're making it up. And that is not professional service. One of the first tenets in our ethical codes is that we are competent in what we do. We don't just make stuff up. We don't just tell people something because it's convenient. We are operating from a knowledge base that has been proven through science. It's called evidence-based care. And most state law says that we have to deliver evidence-based care, and so do the ethical codes for all of our disciplines.
So who is telebehavioral health treatment most effective for?
It's a difficult question to answer, because if you're the heart attack patient who just got saved, it was most effective for you, right? But in general, if you look at who uses it the most, the behavioral community does, because behavioral healthcare is the largest and unmet need in this country. If you look at the physician population, for example, there are about 700,000 physicians in this country. There are about 1.3 million behavioral professionals of one ilk or another. And there are 9 disciplines in our world, by the way. Psychologists, psychiatrists, social workers, counselors, MFTs. This is 9 different groups like that. But the 1.3 million. So we're almost double the number of physicians. And we're the people that are out in the trenches talking to people day to day. Whereas a physician is only involved in behavioral health care when they go to the primary care. Maybe if somebody's a little bit depressed, so they might get antidepressant, or maybe it's a little more serious, they go to a psychiatrist. But the psychiatry is 2 to 5% of the entire behavioral population of all the healthcare providers. Okay, so they're a very small group, and that depends on whose research you're reading, who's estimated the number. But the other 95 to 97% of the folks out there are all these other disciplines. And so they treat a lot of people. And when you say, who's it most effective for? Well, it's most effective for the people they reach, and it's most effective in terms of numbers by the ease to which you can actually deliver the care. In the behavioral world, we generally don't touch people. We don't have to measure things about them. We don't have to palpate their abdomens, for example, or take blood pressure. Psychiatrists are now more and more under pressure to do that, to take blood pressure, but just psychotherapists generally don't. So there are things like that you could do remotely with certain devices that maybe you plug into your cell phone, but most therapists don't do that. The preponderance of approved and reimbursable telebehavioral health is done through video.
I could see it being effective for both the busy executive and the person who's a rural community member where there's not a lot of access.
It's effective for the busy mom who's got 4 kids and wants to bring one in because he's getting in a ton of trouble at school. But now she's got the other 3 she can't leave at home. She can't afford babysitters. She may not have a car. She can't put all 4 kids on a bus and take them. It really gets unmanageable, depending on the children. So it's helpful for lots of people who work in all kinds of jobs. The problem that I see, though, is that there is an oversimplification of the process. And you'll see this with employers that are trying to hire digitized services that might, for example, just go through text messaging. Let's not bother with the whole video, big hassle with that. How about we just text message people? And when I talk to those companies and I say things like, could you send me the articles that are the evidence-based that show beyond a doubt that you are as effective as in person? I don't get anything that is substantive. I get a handful of articles. I just did this with one of the larger companies, 2 of which were not yet published. Well, I'm sorry. If you're an author, you've not published your book, you're not an author, okay? You become an author when it's published. So if you give me an article to substantiate your model, right, your business, and it's not even published, give me a break. This is not an article, all right? It's a wannabe kind of draft of some paper. But getting a peer-reviewed group in a respectable journal to approve that can take years. And a lot of times they'll just send you back to the drawing board and say, forget it, we're not even approving this thing. There are not substantial articles that I have seen that support some of the models that might be out there getting millions of dollars of financial support from investors. And what do we see? They throw a lot of that money at consumers and marketing. They try to let you believe that these services are the digitized version of in-person care. They're not. Don't take your child there. Don't take your angry spouse there. Don't take yourself there. If you need care, get the care that is approved by licensing bodies, licensing boards in this country, because the folks that they have approved are following models that make sense, that somebody's proven are effective.
What's the average length of treatment for somebody working with telebehavioral health informed therapists?
I think we're getting at an issue that is a very common misunderstanding. People think, let's say you go in for ADHD treatment for your 8-year-old who's acting up in school. And you say, hey, this child is a problem. The teachers are all complaining. They got suspended 3 times. They won't let them back in the school. What do? I need some treatment. Okay. Whether you do that in person or through video, or you augment the in-person care with telephone care, or perhaps you download an app that helps you track this child's behavior, and then you upload that information to a therapist that you see through video, makes no difference. It is still ADHD treatment for your child, and that child and what that child needs is what's going to determine the number of sessions. So doing things on video or telephone or through an app or through texting, which is very problematic because of the limited amount of information you get, does not alter the number of sessions that you get, no matter what these startup companies want to tell you. If you get half-baked care or you get fully baked care, I encourage you to get care from somebody who understands and then uses technology to help make it more relevant to you. And I'll give you an example. Okay. Back in the day, when you go in to see a therapist with your child, let's say in this case, the child, they would say, well, how many times, they ask you to do behavioral measures. How many times, here, take this chart home, and chart, what Johnny did, over the week, right? So a lot of people don't have time for that. They sit in the waiting room and they fill the chart out. Oh, let's see. Thursday morning, there was a big meltdown. Hey, okay, so I'll put one there. Yeah, Saturday afternoon. Yep, that happened. Okay, so it all gets pieced together the day that you go in, typically, okay? Now, if you have an app that you can go enter something into very easily with your voice, you click the button, little microphone, and you just voice record that there was a meltdown on Thursday morning and Saturday afternoon, okay? As it's happening, and it triggers questions for you to come on the screen and go, how many minutes? You go, 20, and it asks you questions like that. That kind of thing is much more real-time and accurate than trying to remember this when you're trying to keep Johnny in the seat, in the waiting room, and you're trying to fill out this form and the pencil falls on the ground. As all this stuff goes on. So apps can help you be more precise, you see, about what you're doing. But is that tracking going to make a whole lot of difference in the number of sessions? It may or may not. Maybe you have a lousy therapist, it takes you longer. Maybe you have a great therapist, it takes you shorter. Who knows? Maybe you have such a great therapist and now you want to bring up another issue, right? And now you're going to be there for twice as long as you have 2 issues you're dealing with or 4 issues. So that kind of thing is really tough to measure. But can we say that apps are more real time and more accurate? Yes. Can we say that video conferencing is as accurate as in person? Well, it depends. If all I see is your head, all right, when I'm doing treatment with you, it is not as accurate as if I see all of your body and you've got a nervous twitch in your leg, you see, and when you are about to tell me something that's not quite accurate, your leg starts bobbing up and down like a tell, okay? Therapists are very in tune with this kind of thing. Therapists are trained to watch you. If you say, oh, that's not a problem, but you're gripping the chair and your knuckles are white, we call it white knuckling, okay? Then we know something's up and we know to ask another question or 2 or 5, So a psychotherapy treatment is one where you're having a verbal exchange, but the clinician is listening to your words, your voice tone. Is it slow? Is it fast? Is it high pitched? Are you dragging? That kind of thing, as well as, do you give us any other signs that what you're telling us is hiding something beyond it? And therapists who are good can pick up on that. Did you blush for a nanosecond there? Okay. If I can catch you blushing, I know something else is going on. You didn't tell me. What is that? If I'm a good therapist, I'm going to go get that because that's probably the key to what's really brought you in the first place. You see, those kind of unconscious or unspoken cues are what gets caught. Now, let's go back to the video. Can I see those on video? If I, the therapist, am operating on an iPhone and my screen is 2 inches by 3 inches, probably not, right? But if I've got a 52-inch monitor in front of me and your head is bigger than life, you're 1.5 times the size of an in-person kind of person, then I could probably see a whole lot going on in your face. But I can't see your hands and I can't see your foot. Now, some places will ask you to go into the traditional model for telehealth is that you go into a healthcare facility, like a physician's office, and they have a designated room for video. And that room will have multiple cameras. And I will be able to, there's one camera off in the corner that shows me the whole room, then I can see what your leg is doing. Is your leg bobbing wildly up and down? You go, okay, something's going on. I better ask you, what's going on with your leg? And then watch you while you tell me something. You see, that's how a therapist operates, is they try to piece it together, not to catch you in things, but to make you aware of the fact you're being inconsistent. And it's the inconsistencies in our life that mess us up, you see? So they try to help you straighten out by by having you bring all of this information, on the table here. You look at it and say, oh, well, okay, now what are you going to do? Here's all this information. What do you want to do about this problem in your life? Because it's not the therapist's job to tell you what to do. They kind of help you lay it out. So that's how therapy operates. So you see, some of the foundational questions that a lot of people ask really are not quite the right question when you start understanding how telepractice works.
And using the technology to increase the ability to observe these symptoms or these behaviors. And so having the right technology is important, would you say?
Very, very important. Let's get back to the kid. Okay, so you've got a mom coming in with an 8-year-old boy who has a lot of difficulty. Let's say he's ADHD, attention deficit hyperactivity disorder, a lot of difficulty sitting down. All right, you cannot expect that child to sit in front of a video, even if you bring the video service to their home. Don't expect that child to sit there with his hands folded for an hour. Not going to happen. All right. But if you have two cameras, let's say you have a tablet. You have two tablets, or a tablet and a laptop, or a tablet and a desktop. Now you have one. You say to the mom, put the camera, put the laptop off in the corner of the room, or the tablet, whatever. And now we're going to talk on this one. I'm going to see your face, and I'm going to see the other camera feed coming in. It's called a multi-point. Now I'm going to watch this kid as this kid bobs around the room. Okay, so the kid is floating around, hitting this, doing that, distracted. The door's locked. Child cannot leave the room. Okay, so then, we probably could try at 8 years old. They could probably try, but mom, you can see how mom is coping with getting the child to stay in the room, even though the door's locked. You see, so there's lots of things that a therapist can observe. But you're right. You've got to have the right equipment. You have to know what the problem is. Okay, if you're going to put yourself out there as an ADHD specialist therapist, you need to be properly equipped. And a lot of therapists don't know that. They don't know the options. Why? Because they haven't gotten the training. They have not bothered to go get the training that is ethically mandated for them to do any new type of service. You cannot do, let's say, adoption services with adults who want to find their birth parents without having gotten some training in that area. Just because you yourself are in that boat doesn't mean that you are able to deliver professional services. People who are looking for therapists really need to find therapists online who are professionally trained, have gotten continuing education, continuing medical education training to deliver telebehavioral health.
So what skills, habits, or tactics can clients and therapists adopt either during their sessions or in between sessions to improve the effectiveness of their treatment with a telebehavioral health therapist?
I think the first issue would be for the patient, the client, whatever you want to call the person who's using the service, to know that the therapist is not in the room with them. And so the therapist may need to ask extra questions, which some people, when they're in therapy, get annoyed at. They don't like to be asked 50 questions. They just want to say it once and be done with it. But if you're not in the same room, you're limited. And so the only thing you can do is ask questions or ignore it and then make assumptions. If somebody's asking questions, it's because they don't want to make assumptions. They want to take the time to find out the truth, all right? At least your version of the truth. A client, a patient would do best by tolerating and even inviting extra questions. Am I being clear, doc? That kind of thing. The therapist needs to do the same. Am I being clear? Do you see me? Do you hear me? This is at the start of it, okay? Is your door locked? Reminding people, this is not grandma coming in for a little Skype session, to hang out with you and the family for an hour. This is a professional service. You have, let's say, in the case of Johnny, okay, a child who is causing a fair amount of havoc in your life and his life. And so we're going to try to straighten this out. Okay, so we're going to take this seriously. We're not fooling around. And I think there's a diminishing of the seriousness of the professional contact with some of the ways that some professionals are approaching treatment through telehealth, as well as some consumers, where they want to just relegate all this to a text message. The devil's in the details. The secret that is going to unlock the problem is not going to come only through a text message, right? If it was so obvious to you that your simple words would allow you to come to a solution, you would have done this on your own. You don't need a trained professional to sit with you to put two and two together. Most people don't, anyway. And like I said earlier, I haven't seen any research that says that just text messaging alone is effective. Although a lot of the people in these companies would love to say that and do say it readily. But when they're asked for the research, they can't produce it. Not that I've seen. So in any case, people having an open mind that this is not a dilution of, this is not a replacement for in-person care. The only thing is it replaces is that your body has to be in the clinician's office at the time of the service, or that your body has to wait in the waiting room to get to the clinician. Nowadays, you actually can be in another professional's office, let's say a physician's office, or service to the home, to unprofessional settings is increasing a lot as well. So you might be in your living room, which frankly, I would rather work with somebody in the living room because I can see what's going on. If I look at Johnny and his mom and the living room looks like a tornado hit it, then I may have a better clue as to why this child is acting out, you see? But if the living room is very tidy and everything is in order, then chances are the environment may not be triggering as much reaction in this child as the child who, in the living room with the tornado that hit it. You understand? So the environment has a lot to do with helping a child be relaxed or helping a child be more and more panic-stricken in terms of being very reactive. Having a clue into that, seeing into the home is very much like, and you being a social worker, Bridget, probably can appreciate this, social work evolved with home visits. The early version of social workers going to people's homes and the information they gathered there, not just the condition of the home, but are people eating full meals? Is this a healthy environment? Is there heat? Is there water? Is there hot water? Are there the windows that close? All kinds of things like that the social workers could help. And then they were bringing community services to help people that really were struggling, right? So back to the old model of, we can deliver service to the home. And what can we see there? Maybe there are 50 cats in this home, okay? Maybe there are 5 generations in this home. So all kinds of things that can be learned with the visit to the home. So I personally am very excited about the prospect of that. The problem is creating a situation in the home that is secure. You see, so that if the person talking to you wants to say something privately, you, the clinician, can assure that that is happening. Let's say 8-year-old Johnny has a 17-year-old sister who's very internet savvy and has a Bluetooth headset and can sit in her bedroom and listen to everything Johnny is saying to the therapist. This might be a lot of fun for her, you see, but it's compromising Johnny's privacy. And it's the therapist's job to have covered all the bases to make sure that kind of stuff isn't happening. And most therapists don't know how to do that, which is why therapists that just jump on the net with any client that's willing to see them through a video camera are doing their clients a grave disservice. I've just mentioned 2 examples here of things of that therapists need to be aware of, you see, when you deliver services. And so there are actually 149 competencies. This is why I chaired a committee to come up with telebehavioral health competencies, because we've heard so many clinicians reporting circumstances that make absolutely no sense. And they learn their lessons the hard way after they hurt somebody, after someone's privacy is compromised, after a battered woman says something and then gets battered that night by the husband who heard it. You see, there's all kinds of things that can happen and have happened. People have committed suicide as a result of their telehealth exchanges. There are a number of things that the clinicians who don't bother to stop long enough to think about, am I professionally trained to do this, don't know. In any case, we've identified 149 of these. They're called competencies. They're sort of the building blocks of any type of care, and they are discrete. It's a piece of knowledge, it's an attitude, or a skill. I know how to secure someone's privacy in their home. That's a skill, right? I mean, it's knowledge, but it's also based on a skill. I need to do certain things, right? A skill is something that's done. And so these are 149 competencies. So that's why we worked as a team, an interprofessional team, 6 different disciplines to come up with these for 4.5 years. And we published them in 2017. And now we're developing studies to explore how effective we were in our, because it was theoretical, right? And these are all leading clinicians. One was the past president of the American Counseling Association, just, I mean, very notable people that sat down with us and did this for 4.5 years, I mean, over that time. There are a lot of things that people have heard about and studied and put into this. So now we have these competencies. We want to see how accurate we were. How can we trim them up, basically, to make them better? So we're actively involved in that at the Institute. But the Institute, the training that we offer at our Institute are based on those competencies. So we train people to be able to handle those competencies.
So who is telebehavioral health treatment not appropriate for?
That's another question that has a lot of misconception involved in it, okay? It's appropriate for anybody, but the thing that's the variable is the setting, okay? A lot of people don't think about the setting, but that's what changes, right? You're not in the clinician's office. So the initial telebehavioral health, back then would be called behavioral telehealth, and then, like I said earlier, evolved to telemental health, right? The initial sessions involved psychotic patients, bipolar patients in mental hospitals, and oftentimes on locked units. What's the important variable? Well, they had staff there, right? They had staff to set all this stuff up. And if something went wrong, then you give a call to the nurse's station. You say, hey, just want you to know that Pete over there that I talked to told me he wants to kill himself or he wants to kill somebody else tonight. Oh, okay. So then they know how to handle that there. They help with that. But if you've got a psychotic person in their living room with 3 kids in the next room banging on the door, that is not a good situation for telehealth. You need the police. You need to be reasonable about this kind of thing. So it's really a matter of the setting. Actually, I mentioned the police. There's a lot of telehealth that's happening in our prisons because people get arrested. And the police are not trained to know, is this a mental condition? Is this a intoxication? They can smell alcohol, but is this person intoxicated and psychotic or manic? Is there something here that's beyond the fact that this person's unruly and just needs to be off the streets for 2 or 3 days? In which case they would have a community mental health practitioner drive over and do an evaluation. Well, that doesn't need to happen anymore. That drive doesn't need to happen. And the clinician can stay in their clinic. It could be 100 miles away and just do it over video. So you see, it's all about the setting.
That's exciting.
It's very exciting, yeah. And telehealth, telebehavioral health, has a long history of being offered in our correctional facilities. So not just jails, but our correctional facilities and schools where children would go to the school and be called down to the nurse's station. Meanwhile, mom and dad would have driven up in their car, parked the car, and walked in and go to the nurse's station, and they would have a family therapy session with somebody who could be 3 counties over. And this could happen every week. And typically what happens with family therapy is that the child is excused and the parents continue because it's a matter of knowing how to set limits on that child, no matter what the behavior of the child is, and both parents being on the same page with it, you see? So there's a lot of training that needs to go in there for the parents, oftentimes more than the child. And then you bring the child in and have the parents do what they should be doing with the child. And then, eventually things get solved that way. But definitely in schools, in specialty schools, schools for autism, for example, where you bring the family in who may never come in to the actual school, but do it on a tablet or remotely. They've been in nursing homes, a tremendous amount of work being done through telehealth, obviously because patients are stationary. They're oftentimes cannot get out very easily. They're wheelchair bound. So there's lots of those kinds of assessments and treatment that get done. General hospitals specialty hospitals for children, you think about a child in a cancer ward, okay? That child is traumatized. There's no way you can go through cancer treatment and not feel traumatized. You just stick a hypodermic needle in a child's face and you'll see trauma, okay? Now imagine a child that's getting injections on a daily basis or IVs or repeated surgeries and all of the medical workups and all this. These children, they all need somebody to talk to. So there's especially hospitals like that. There are many drug and alcohol treatment facilities that have done aftercare with telehealth, emergency departments, emergency rooms, emergency departments that a lot of times people go in for a psychiatric workup and they will sit in the hallway in a gurney for days. I heard one case where someone was in the hallway for a month. How do you stay in a hallway on a gurney for a month? They have to knock you out to do that. They have to sedate the person, right? I mean, there are things like that that go on. Now you can just pull up a remote clinician. And a lot of times social workers are doing this now, where you could do an evaluation, a screening evaluation. This person needs to be admitted to a drug and alcohol treatment facility. There's lots of things like that, triage stuff that can really be done out of emergency departments. A lot of primary care offices now are moving in with telehealth services where they'll maybe pull in an oncologist, or they'll pull in all kinds of things, specialty services through telehealth. So there are many different applications of this over the years.
So if you had a magic wand and could improve one thing about mental health treatment today, what would it be?
I actually believe that there is a transformation that's happening in healthcare right now that most consumers, and sadly enough, most clinicians do not expect. Now, if you stop and think that the iPhone was released 11 years ago, and think about how the iPhone has transformed our communication, and it's not just ours, but worldwide. Think about all the apps that you carry on your phone, even if you have an Android, so the Android, Apple, they are the competitors. But think about 10 years ago, 11 years ago, 12 years ago, this stuff was barely even there. And most of us, if we leave our home without our phone, given how far away we are, we probably would turn back to go get it. It's something you just don't do without. And even if it's just your flip phone, okay? Most people are really dependent on their phones. Imagine that this technology world is evolving exponentially. So next year, it won't just be twice as fast as now, but many times faster, okay? Many, many, many times faster. Because now we have computers that do our thinking. We have computers that develop our technology. So in a very few years, much of healthcare will be through technology. And the sad part for me is that most clinicians don't see that or don't believe it, because you can't adapt to something if you don't see it coming. And very few clinicians are willing to take a good hard look at how they can help transform that world rather than letting the business community do it. And so we have people that are throwing tens of millions of dollars at funding companies that don't hold their own clinically to deliver behavioral as well as other services. And there is no way to stop that. What they think they're doing is disrupting traditional service. Now, as one of the innovators, someone's been doing this literally for 25 years. I am all for disruption of things that are archaic and no longer needed. But there is a lot in psychotherapy that I really don't think is appropriate to disrupt, because it degrades it. And it's hard enough to deal with, let's say your husband's mentally ill, okay? Hard enough to deal with a mentally ill adult before you really get it and they get it that they're mentally ill. Hard enough to do that in person. Now we're going to degrade that, dilute it, if you will, with some half-baked business model for how you're supposed to be getting psychotherapy. It's not a service. It's actually setting the field back in the name of innovation, which is just ridiculous. Much better to follow the rules, however slow they are, follow the rules, make sure you know what you're doing before you jump out there and do it and hurt somebody.
How can my audience learn more about telebehavioral health, either online or in print?
Well, they could come to telehealth.org. That's our website. And they could look around for our professional services. We offer consultation as well for professional groups that want to get started. We do not serve the consumer public. We are, like I said earlier, I had a consumer magazine, but we shut that down because I decided I really needed to focus on training clinicians. If somebody is seeing a therapist who cannot answer a straight question about where did you get your training and how many hours did you get in your training for telehealth, then I'd encourage them to ask their therapist to go get some training in this and to send them on over to the telehealth.org site. And people then ask, well, what's a reasonable number of hours? Our minimum number of hours for what we credential, that we give a certificate for, is 15. And I'll tell you why. In a court of law, if you imagine that somebody does, let's say, marital counseling, and they're up on a witness stand, and the opposing counsel says, well, madam, how many hours of training did you get in marital counseling before you treated Mr. and Mrs. X, and now Mrs. X is dead and the husband's blaming you? 9 hours. Huh. And what made you think you were an expert after 9 hours of training? Oh, wait a minute. I better get my ducks in a row as a clinician and find out what I don't know. Go figure that out. So 15 is really the minimum. We have 2 programs. One's a 15 and another one's a 36-hour program.
And that's one of my passions for this podcast, is for consumers to have the knowledge so that they're armed with the knowledge to ask their therapist, well, what is your training in telebehavioral health? What is your background? At least they know the questions to ask. So Dr. Maheu, on behalf of myself, my listeners, and all of the people you have helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of telebehavioral health.
It's been my great pleasure. Thank you, Bridget.
I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you, someone you love, and people around the world can benefit more from therapy. There is no need to suffer in silence. Get the help that you need to create the life that you want.